He's working with Nas's fellow, and he's going to present a few cases. And then Lukan's going to present a couple cases, and then I thought we'd talk about the meeting coming up next month. So, Hakeem, are you ready?
Yep, I'm ready. Thank you for the introduction. Should I stand in the front?
Hakeem here.
Okay.
Okay.
Okay, so Joaquin, I'm just going to start running your video, the sickle cell RANA. Is that right?
Okay.
1 second.
Perfect. So thank you so much for the invitation. This is a recapitulation of cases we've recently done in our retina service, and we've been playing around a little bit and exploring with Intraoperative. This first patient was a case of vitreous hemorrhage related to sickle cell. There was no traction, but there was a temporal vascular proliferation that was noticed in the temporal retina. When we change into Intraoperative, you can notice significant peripheral ischemia that was first delineated and then treated with conventional laser. I think this is a very useful technique because let's remember that blue light is toxic to the retina, so you will want to diminish the time you use the blue light into the eye. So you first delineate and then you complete the laser to the aura, as was done in this case. We get a lot of sickle cell retinopathy here in the Dominican Republic. The second case is another advanced case of sickle cell with macular dragging and peripheral traction, and in which Intraoperative becomes a very valuable tool because we've noticed that the ischemia perceived clinically without Intraoperative is a little bit more than the ischemia seen with Intraoperative. So you only treat the areas you need to treat, preserving more visual field to the patient. As in the first case, we first delineate and then we complete the laser with the conventional illumination. We have like 3 different filters, one green, one blue, and one grayish. That is my favorite, so we change into the filters in the case. This case was a case of sub-island hemorrhage. We were not sure if it was a neovascular membrane or where did the hemorrhage come from. So with Intraoperative, you can notice that there's a leaking macroaneurysm in the macula that was responsible for the hemorrhage. This is our last case, probably the most interesting one. This was a baby that we were following up with ROP that got lost and returned 2 years later with a total retinal detachment in the other eye, and this eye with a vitreous hemorrhage. There was this very thick membrane. We were not sure in the moment if it was hyaloid, if it was retina. As you can see, there's a very big bridging vessel between that thick membrane and the surface of the retina. We proceed to trim that membrane down very, very, very carefully and proceed to do Intraoperative. And as you will notice very soon, you can clearly see the ischemic areas in all the inferior and temporal quadrant. That's my favorite filter of all. And as in the previous cases, we proceed to delineate the areas first with the laser, and then complete the entire laser into the aura with conventional illumination. This baby is very good actually right now. I think so. Intraoperative is a very valuable tool. That's all. Thank you for the opportunity.
I like that gray one. What's your settings for that more gray? Because it seems like the gray allows you to see not only what you're doing, but get the FA aspect pretty good, but still be able to manipulate inside the eye with decent visualization. What's the actual? Did you come up with the gray settings, or is that something already on Ingenuity?
No. I can tell you. I like this one because it allows you to see leakage better. And in the videos, it's better for presentation.
Yeah.
I believe, I don't remember exactly, but the CM was 0, magenta 100, and the yellow, it's like in 50. In the advanced settings, I believe saturation like 40. And that's all. I don't remember exactly the parameters. I could share it later on, but it's very
Yeah, no worries. Yeah, looks like it.
Is this version 1.4 or 1.5?
No, this is 1.4. We don't have 1.5, and I believe we will have it soon, because in Latin America it will get later.
Okay. I mean, this is great video. And the other thing that's interesting is I think you kind of see a little better through the vitreous hemorrhage with the fluorescein filter to some extent.
Yeah.
And this you can really see the ischemia well on here. So I think that's one of the big advantages to intraoperative FA is that we all talk about lasering ischemic retina and preserving non-ischemic retina. The study for proliferative diabetic retinopathy in the clinic didn't show a big benefit to targeted laser, but I think part of that is that the vitreous is still attached. There's still some traction if you're doing a vitrectomy, you're relieving all the traction. So I think that we definitely need to revisit that and see if we can preserve more visual field and keep the rates of post-op hemorrhage nice and low.
Yeah, I 100% agree. And I think another indication for this is that in those diabetic patients, you can do intraoperative and you can see the vascular profile of the macula, so that you can talk to the patient later and say, here, we took out the hemorrhage, but this is what you should expect later on if there's macular ischemia present.
Yeah, exactly. Just on this baby, it looks like you left a little bit of that vitreous. Did you wind up taking all that out, or just leaving that area that was kind of difficult to tell whether what plane you were in?
No, we actually left it like that. The patient is actually doing very well. It's all attached. So sometimes less is more, on the eye.
Yeah.
Less is more. The patient is fine right now.
Yeah, I don't see a lot of babies, so that's interesting. So yeah, these are great cases.
Thank you, Alan, and thank you for the opportunity. It was a pleasure.
Oh, sure. Anybody have any questions for Joaquin? We'll move on to Lukan.
Hi guys, can you hear me?
Yeah.
Yeah. Thank you all for inviting me to present here. Can we play the video? This is a case where there was a hemophthalmos due to advanced age-related macular degeneration. And the filter that I'm using is optimized actually for the Revalia microscope, because since I play a lot with these filters, I realized that the spectral transmittance of size like Alcon Mueller video actually are different, and it relates to the contrast of the image that we might have. So I also played a lot with the different colors of the image, but I do believe that we need to stay to the classical black and white representation of the fluorescein angiography that we are used to see from the fundus cameras and SLO devices, because it's more natural and we don't need to translate what we are already used to see in the classic FFA image. So here you can see that with indentation you can see the peripheral vasculature and even the choroidal perfusion. If you have a good amount of contrast and good settings to capture the fluorescence of your image here. So what I need to show here is actually the contrast and the data separation that we need to aim to have during intraoperative FFA. Otherwise, if we see only the big vessels, we might miss areas of non-perfusion which are on level of the capillaries or on the level of the choroidal circulation. So you can see here the macular region, and this was the first case. This is a case of advanced proliferative diabetic retinal disease, where of course we will do first the fluorescein angio, and later on we will do fluorescein angio guided endolaser, and it will be done only under a chandelier light. I heard something about the blue light which was harmful for the retina. It is right for the spectrum under 440 nanometers. We are using here roughly in between 475 to 490 nanometer as excitation, and the level of safety is absolutely the same as in the rest of the white light spectrum. Otherwise, all the SLO devices wouldn't be using the same wavelength, like 408 or 490. So in terms of safety, or probably more of the ability to indent and laser, I developed a way to have a good fluorescein angio image with the chandelier. Now this is still a striped light. I call this FFA navigation or intraop guided endolaser. And now you see, now I am with chandelier, and we might agree that the chandelier level and intensity of light is like at least 4 times weaker than the striped endoilluminator, and it's also far away from the retina, meaning that there is no harm. So if we have a good setup of image excitation and digital filter to capture the fluorescence, actually we might see pretty well the areas of non-perfusion and the areas that we need to laser. Also, what I would advise is during this laser to lower the power of the aiming beam, just to not interfere to the rest of the image. So you can see how gently I can laser only the non-perfused areas in the far periphery, and I do believe that this is the right way to go, especially in order to somehow protect the eye from NVG strike, because this is the main problem of such eyes with advanced ischemia, that after the good surgery we might end up with acute neovascular glaucoma. So here, due to the specificity of the endolaser, I do believe that we cause less post-operative inflammation, which directly relates to the health of the eye itself and most probably to the macula, because in the diabetic eye, albeit or along with the ischemia, there are a lot of inflammatory processes that are going on, and on top of that, when we laser the retina, we induce again inflammation. So as Alan mentioned, if we are able to preserve more from the visual field without leaving areas of ischemia, we might assume that in a vitrectomized eye, this could be beneficial in terms of longevity of the functional outcome of the eye. We cannot remove the diabetes disease, unfortunately, from the patient, but still we can be more precise in treating the underlying pathology. So here I find quite useful the chandelier assisted intraoperative fluorescein angio, and with the proper digital filter settings you might have actually not bad image at all. And yeah, I'm trying to somehow treat all the areas. Of course I might miss something, but after I switched to the classical view, I was surprised to see how much healthy retina or unaffected retina was spared. Otherwise, in other settings, we just laser the periphery and we kill a healthy retina. And since we are surgeons, I think that we need to be more precise, and I like that I have the ability intraoperatively to be guided, like the neurosurgeons are doing it like for the last 10 years, because they also have these imaging modalities. And I think this is a huge step forward in how we might treat the vascular pathology of the eye. This is diabetic case, but we had another case which was peripheral occlusive vasculitis, and again it was useful because we found the diagnosis with the intraoperative fluorescein angio because there was a hemophthalmos. Now here you can appreciate how much laser is done and how much retina is actually spared from our laser. So basically these are my cases.
Lukan, these are beautiful cases, as you always present. Just a couple questions. You mentioned about the light sources. Do you have, and I think I've seen you present something in terms of the different outputs of the different light sources. Do you have a sense that one light source is better than another one? I mean, we've modified the constellation, but I don't know whether the profile, whether there's another light source that may have a better optimization for an exciter filter.
I have a few light sources and they are multi-wavelength capable, but they are all xenon based. For example, this image here is not achieved with the constellation light source, the one that we are seeing in the moment, but the intraoperative guided endolaser was with the chandelier was achieved exactly with the modified constellation. And I think that probably the type of the exciter filter that is used has something to do with the level of excitation. But this is one part of the equation. The other part is the optimized digital filter, so the ingenuity settings. Because I don't use any barrier filter at all. Simply I don't need to use it, and these are the images achieved with the digital filter. So probably if I need to make it in percentage, 30% will be for the endo illumination and 70% will be for the digital filter. And also probably the quality of the microscope, because I found that different microscopes, I don't want to name them, but some of them are inferior in terms of image clarity and contrast compared to others.
I think that Michael Cardamone, he talks about just when you're setting up for intraoperative FA, you need to do all the basics of good microscopy in terms of having your lenses clear, being parfocal.
No, I'm basically talking about the quality of the optical parts of the microscopes. They all use different type of glass inside coatings and things like that. And I found that the microscope as basically objective of our camera has a huge role on the image.
Yeah, the other thing sometimes we found is depending on how we do our barrier settings, we'll see the choroid versus the retinal vasculature better or worse. Do you find that at all?
With this filter that I'm using here, basically I see everything. I mean, I see the vessels, I see the choroidal circulation, and I see the capillary dropouts. So as I said, I played with the different color settings and I give up, meaning now my main aim is to achieve as much as contrast in the image as possible, because when you have a contrast, and basically here this is a dark white contrast, you will achieve better separation of the details. So this is
I agree completely.
This is my personal opinion. I started with greenish, bluish filters and things like that, but I think they actually obscure the vascular picture, because here we need to focus on the vascular appearance, not to the rest of the retina. Of course, I agree that we need to see the retina in order to work safely, but the aim of intraop FFA is actually to evaluate the vascular network of the eye.
And I agree, and I certainly, black versus white contrast is the highest contrast you could get. So, why wouldn't you use it? Mm-hmm. So that's something that we're aiming for now.
Yeah. This image, which is on the screen, is achieved with Constellation Chandelier.
Okay.
Yeah.
Okay. It's a great image. I don't know. I don't know if Maria was in the audience, but I had, this obviously prior to intraoperative FA. Years and years ago, if I had a diabetic and they didn't look, if they were advanced, I was doing heavy PRP. I think if there's advanced diabetic eye disease, you don't have intraoperative FA, you're obligated to do pretty heavy PRP.
Yes.
Though I've had a handful of patients where they didn't look all that advanced, and we did some peripheral laser, but tried to spare kind of the post-equatorial retina, or the retina closer to the arcades. And they did great for several years, and then several years later they came back with NVG. So what I've been doing recently is all treat, as you have, the areas of ischemic retina, but then the non-ischemic retina, I'll just do a very light scatter Because I guess I have the sense in some of these patients, their retinopathy won't progress so much because they're post-vitrectomized, but they can become more ischemic. And I didn't know if anybody else has seen late post-vitrectomized eyes turning, getting NVG.
At least I saw a lot of them, and I don't think that even the targeted laser can prevent the evolution of the diabetic retinopathy, because the diabetes is there, it's here to stay. So we only might hope to prolong the longevity of the effect of our surgical procedure, but ultimately sooner or later they might progress to NVG.
Sure. Well,
but sorry to interrupt. Another thing that I had was after a heavy PRP laser, like 2 to 3 weeks, everything is fine, and then massive shrinkage of the retina and tractional detachment, which I attribute to the huge inflammatory response that we are actually inducing with the massive laser. So probably a balance in between heavy PRP and targeted laser therapy, as you mentioned, light scattered laser in some areas which are not fully influenced by the ischemia, something like that.
Mm-hmm. They're great videos. I have a couple videos that I can show. They're just montage videos. I'll show those for a little bit, and then we can talk about next month's meeting.
Sure.
All right, I'm happy to bring those up. Are you going to need your presentation as well?
No, we'll just do the videos. I think everybody.
Oh, very good.
And Lukan's talking about before I roll the videos. Lukan's talking about this this presentation that he's done, or this video that he's done with the Constellation. If you're using the Constellation light source, and we just need to get a video of this. It's just it's very easy to switch back and forth from fluorescein, because our exciter filters are in the accessory laser filter. Our exciter filters are in the accessory light source. So we just take the lights off the primary light source, put it into the accessory light source, and go to the FA channel on Ingenuity. Man, we're ready to go. It takes 30 seconds or less. So I know a lot of people that are thinking about adopting it. They think it might be very complicated to carry off in the OR. Once you do the background and have your machine set up correctly, it's really pretty seamless. So we can go ahead and roll the video. So this is just showing the detail that we can get. And just a little bit of a grayscale video. But this is an eye with uveitis. And we saw some vasculitis, but the big lesion superiorly that we couldn't see before really didn't look all that active. So this patient got some post-op steroids, but wasn't hammered with it, and wound up doing well. We thought it was sarcoid based on the scan, or based on the intraoperative FA. This is macroaneurysm, and here, you can see it, especially when we're doing the laser with, you get kind of a retroillumination, and you can see the extent of the full macroaneurysm. So this we treated a little more, extensively.
Hit the second video now.
Okay, I got muted for a second. So, so the macroaneurysm, if as we go back and forth for treated versus untreated, we really got an extensive treatment of the macroaneurysm. This patient did well and had no further vitreous hemorrhage. We can go to the next laser, next video. So this is a diabetic, and this is still, you can see we're playing with the settings here. And we see a lot of these residual vascular abnormalities. And here's one where, and this is similar to what Lukan was showing with this is a chandelier with the constellation. And you can see these, peripheral areas of intraretinal neovascularization. And we're actually treating these fairly confluently, as well as the ischemic retina peripheral to that. And then, we also see these hot spots once we take out vitreous hemorrhage. And some of them, you can see a little hemorrhage around with the standard view, and some you can't. And let's see, so this is actually we're peeling under fluorescein guidance, and this is something where I've actually found it to be very helpful. We also have a channel where we think we can see the membranes better through the blood just on ingenuity without fluorescein guidance. But if you see these areas, you can see as you're peeling under fluorescein, as Lukan was mentioning, it's if the vessels have any perfusion, the abnormal vessels are white against a dark background. So you've got a really high contrast situation, and you can really see the extent of the vessels and where exactly they're coming out of the retina. And you can get a nice atraumatic peel. So we'll get to that, I think, in just a second. I can go over that again, and then we can stop the video. So yeah, these are just the hot spots. I think lasering these hot spots and these residual neovascular abnormalities, which we don't really see well with conventional microscopy, will help reduce the rate of post-op vitreous hemorrhage. So again, as I'm starting to peel, some of these vessels aren't perfused, so you don't see much signal, but as you get into the area, you can see, and it's something that projects better on the screen, but you can see how the neovessels are white and the underlying retina is dark. You can get a nice atraumatic PL. We can go ahead and stop the video.
Alan, do you use straight light for all your intraoperative cases?
Yes, I use, I'm spoiled. I'm in a hospital setting, so I use a chandelier light source on most of my diabetics, and then I have a straight light. It's not it's not a wide field light, it's a straight light. So I feel like when I want to get really detail on the tissue, I put the straight light to that area of tissue, and otherwise I have the chandelier, which, as Lukan mentioned, is certainly adequate. With the constellation light source, you can see pretty well. for most, throughout most of the retina with the chandelier light source.
On the Constellation, I must add that a new light bulb is quite better than the used one, meaning that if you have above 350 hours usage, it will still work, but the intensity of the light wouldn't be like as a new lamp. I mean, in the Intraop FFA, for me, it makes a difference. So check the hours of your light bulbs. They are easily seen in the menu, and if it's needed and if you want to have a better contrast, you might need to invest on a new light bulb.
And then, Lukan, you mentioned the xenon light source being a little better on the Constellation you have. The menu has the Constellation light, I'm blanking one other, and then the xenon light. Do you have that on the xenon light?
Yes, all my sources are xenon light with exciter filter.
Okay.
I tried LED with the given wavelength. It seems that the separation of the wavelength, it's not, at least on the source that I tried, was not so good compared to the optical filter. I'm sure that LED or solid state laser probably light source might be more precise in terms of wavelength, but this is something that we need to ask, for example, Alcon to think about it for the next generation end illumination.
Mm-hmm. Sure. No, I completely agree. So.
Also, one thing, Alan, you mentioned the time that the intraoperative fluorescein angio takes from our surgery. When we incorporate this imaging modality, it takes no more than 30 seconds to prepare for the starting of the angio, and then obviously we'll need at least 5 to 8 minutes if we want to constantly monitor the changes during the FFA. Depends from what we want to see. I want to say that we already do this as a routine in our cases where the surgeon, in that case me, feels that there will be a benefit from intraop angio. I just ask my anesthesiologist to prepare the fluorescein and to administer the fluorescein when we are ready with the endoillumination, and it's a flip of a button on the Ingenuity. Also, what I need to share is that we already had our first case of allergic reaction to the intravenous fluorescein angio during the surgery, and it was a slight coughing from the patient. And when we finished the surgery, we observed a rash on the skin. That is why now we are giving 20 to 40 milligrams methylprednisolone along with the fluorescein in order to prevent such hypersensitivity or allergic reaction to the fluorescein. Not a big deal, nothing really special, but it might happen, and we should be prepared for that.
Well, that's a really good point. Fortunately, we've not seen anything, but that's probably from us being dumb and lucky. But I certainly think that that can always present itself. The other thing we've not seen with this is the nausea. So I'm wondering whether we should think about pre-treating some of these patients with Zofran. But we just haven't seen the nausea, and whether that's because they're relaxed because they've got some sedation with the procedure, I'm not sure.
Here in our hospital, we give the patient dexamethasone intravenous. We have not seen any complications related to fluorescein, except one patient that the canalization was really bad. We did not notice, and fluorescein infiltrating the skin. Fortunately, that patient is pretty good. It's been like 2 weeks now. The hand, it's pretty good, but besides of that, no other complications of fluorescein.
Just on a tangential point, I was doing a surgery Friday and our normal angiographer was out. So while I was doing the surgery, I work at a big hospital. The person in the lab came over and did IV access for us, was doing us a favor. So one of the patients that got a fluorescein said she had a lot of burning after the fluorescein injection, and her whole arm was yellow. So I was pretty sure that the lab tech injected fluorescein into the brachial artery. So fortunately, doing the search, there's typically no sequelae of that other than burning for about 4 or 5 hours. But if you've ever seen that, it's something that I really don't want to see again. I guess we've got a few minutes. I was just going to talk briefly about the meeting next month, and certainly I want to keep it interactive. I'd like to have, I was going to shoot for a 90 to 120 minute meeting. I was going to have a few case presentations, but have a few of us just talk about the technique. And then after that, kind of talk about how we can measure the effectiveness of intraoperative FA. I know we're looking at rates of post-op vitreous hemorrhage in our diabetics, but get other people's thoughts. As towards how we can show both the safety of it and show that it may be improving our outcomes, because I think that's what some of the big companies want to see. So they want to see better outcomes, and then safety, and then also how many people are adopting it. And that'll be something that we can talk about, is how we get it better adopted. I think it's one thing where the Europeans are ahead of the Americans in terms of adopting this technology, and how we get the message out. So that's what I was going to mainly discuss, as well as future applications of intraoperative fluorescein. And Lukan's got some, it sounds like, great stuff that he's going to show in terms of visualization. He's really on the cutting edge of all this. Does anybody have any suggestions? Does that sound okay?
It sounds okay, but I'm wondering about the adoption rate. There are surgeons which want to be early adopters, but this is not a product which is given from the companies. So it depends from mouth to mouth communication and settings and things like that. And I think that all of us that are doing it in different way. And we are achieving different images and also different imaging data. So first we need to agree on a, let's say, more or less universal modality which can be then evaluated in terms of clinical trial or something like that. And in order for that to happen, the biggest beneficiary of that is Alcon. So Alcon should be in the equation. And I don't mind a custom, let's say, custom part of the software or something which should be released from Alcon in terms of Intraop FFA pilot project, where the early adopters will have proper settings. Otherwise, they might be disappointed from the view that they get, and they will simply reject the imaging modality. This is my personal view on the topic.
I think that's important. I think we need to have a section on it. I'm actually in a little over a week going to look at a bunch of different filters with the Constellation light source. I think Lukan has done that as well. As to, I think I think the choice of the exciter filter is important, and we can do that qualitatively, but we can actually do it quantitatively, where in the lab we just look at the amount of fluorescein signal we can see through a small capillary tube with diluted fluorescein. Alcon has not funded that project yet, so ultimately it would be good to have some science around it. It's kind of a little bit of a catch-22 is that one thing that Alcon wants to see before they put more money in this is more people using it and saying that it looks good, but without some science behind it, makes it a little more tricky to optimize. So
this is exactly the way I achieved my filters with capillary tube and spectrometer. So this is not a big, let's say, deal. And since there is already an effective imaging modality, which leads the way of how the digital visualization can be beneficial. Otherwise, all the other colleagues are comparing the classic analog view with the color image of the Ingenuity. And of course, the color image of the Ingenuity is nothing exceptional compared to the classic view. So that is why even the Ingenuity is not there is no good penetration of the digital visualization with Ingenuity among the surgeons. And the next step is actually digital filtering and of course fluorescein angio. And the Ingenuity is the only system which is capable on that at the moment. No other digital platform is capable on that at the moment. So I don't really agree that Alcon needs more persuasion on that matter. It's a matter of time to incorporate this. And of course, other colleagues will follow if they know how to do it. You already published a paper with Michael Cardemone describing your imaging modality and how do you achieve your images, etc. But this is a preliminary, let's say, setting, which is, in my opinion, not the optimal one, right? So I do think that we need to somehow reach a consensus on what to be given to Alcon or to the colleagues which want to adopt the technology. Otherwise, as I said, they might be disappointed from the results that they are getting, and they say, oh, this is no use for me, this is just a complication.
Mm-hmm. No, I agree. I think we certainly need a section on optimization and standardization of what we're all doing. I think the one thing that does make it a little more difficult is that different people have different microscopes, and we just have to be cognizant of that, because not all microscopes are created equal. So I think we can come up with something relatively standardized from the meeting that would be outstanding, and then we just have a caveat that, okay, these are the microscopes that it appears to work on best. I think we need to share that as well. I have seen the Bausch & Lomb machine, or the Bausch & Lomb visualization system.
The CWUMA.
Mm-hmm.
I was the first surgeon to do human surgeries on CWUMA. I know it quite well, and they don't have digital filters at the moment. But they have in their patent fluorescein angio, which is achieved by hardware barrier filter.
By what barrier filter?
Hardware mounted barrier filter inside of the...
Oh, okay. Okay.
But they haven't shown anything still.
Okay. Well, I think that's, Lukan, just as an aside, I'm gonna, in the next week or so, I'll put a little agenda together and run that by you, and you know, we'll kind of plan to, you know, run the meeting together.
Sure, perfect. Sounds good.
Any other questions or comments from anybody? Well, I really appreciate everybody's time on a Sunday, and look forward to meeting a lot of you next month in person.
Thank you for organizing that meeting, and see you soon in Amsterdam. Bye, colleagues.
Thank you. Bye-bye.
Thank you.
Thanks, Alan. Thanks, everybody.